So now we're going to the nuclear imaging test. Nuclear imaging is where they still get your heart rate up, but they put you in a nuclear imaging scan to check for your heart pumping. How is it functioning? Do you have any, are your ventricles moving the way it should be moving? Making sure that your blood's flowing the way it should. And it's much less costly than a cardiac catheterization. So it does have a good negative predictive value, meaning that if it's negative, then that's really a good, it's actually a good indicator saying that it's probably is negative and not a false negative. All right. Oops, let me get to this. Okay, here we go. All right, pharmacologic testing are for people that can't run on a treadmill. And so they need medications to speed up their heart rate. And I'll get into which patients are good for what. But again, if you can't walk on the treadmill, the first thing you're going to ask somebody is, can you walk on a treadmill? If they say no, you're going to go to the pharmacological testing. It's whether you're going to add nuclear imaging is the question. So we'll go through that in a little bit. So what this does, it's a vasodilator stress imaging. Lexiscan is one name. You're going to get images at rest. Then you're going to inject the agent. Again, every place has different protocols of what they're going to inject. Speed up the heart, stress it. They're going to stress the heart. And then you're going to get the images after they stress the heart. Now, anybody with COPD, you want to give them dobutamine because it's not contraindicated, where some of the other ones are contraindicated with COPD. They'll have issues with breathing. Stress echocardiography we're still talking about. So it's used with routine treadmill exercise or dobutamine infusion protocol. Now, stress echocardiography means that you want to stress the heart either with medication or on the treadmill, and then they're going to get an ultrasound of their heart at rest and as it's stressed out. Okay, so either you're on the treadmill and you're getting your heart rate to 85% of the predicted heart rate it's supposed to be at, or they're stressing your heart with a medication. So they're doing a baseline study. They're going to compare it with the immediate post-exercise images. And they want to check global, meaning the whole left ventricle function, how it's working, and wall motion analysis. So is your heart stiffened, or is it not pumping as efficiently as it should, which is your ejection fraction? Sometimes you can get limited image quality, especially if they're obese. It makes it a little bit hard. And this is where this post-exercise imaging is really time sensitive. So remember, with the stress echocardiography, it's not a complete echo. So don't think just because you're ordering a stress echo, it's going to be a complete echocardiogram where they're checking your abdominal aorta and really taking a look at every aspect of your heart. So it's really not, it's more of a snapshot, because you're seeing how your heart is pumping prior, then they're stressing, and then you're flipping back onto the table with your heart rate going fast, and then they're checking your heart again just to make sure that you're not having any wall motion abnormalities at that. So just remember that someone that has heart palpitations, things like that, or a history of atrial fib, you don't want to get the stress echocardiography. You just want to get an echocardiogram, because then you're looking more in depth at the ventricles, the atrium, your valves, and see what's going on with that. If you hear a heart murmur, you're going to get an echocardiogram and not a stress test. Okay, so this is the differences between stress echo and perfusion imaging. So are you just going to get the stress echo, or are you going to go ahead and get the imaging too, which is your nuclear medicine, nuclear med type thing. So the stress echo has a higher specificity. It has some more clinical information. It's easy to do. It doesn't cost as much, and there's no radiation, whereas perfusion imaging has a higher success rate. It has a much higher sensitivity, particularly the left circumflexus, which is the front part of your heart with blood supply. It's your blood supply, to the front part of your heart. It's more accurate in evaluating ischemia. in a setting of resting abnormalities. So it's people that are having chest pain at rest, this is really good. You should just go ahead and get the perfusion scan. So I call it a Lexi scan because that's what we have. Lexi scan stress test. It's a nuclear med stress test. And if they need to have a medication to raise their heart rate, then they do that. If they don't, they go on the treadmill, but they're always going into the scanner, the nuclear med scan. But it does cost more, and there is some radiation exposure. No amount of radiation is good. So it's a lot of risks versus benefits in figuring out which one they should have. So interpretation, there's always issues with interpretation. So are there ST segment changes or are there not? Sometimes it's hard to determine that. There's a higher false positive rate in women in the inferior leads. T-wave changes are really common, so do you take that as a problem or do you not? It's usually pretty insignificant. I see T-wave changes all the time on EKGs, which is not, not usually very serious. If they have had a change from their past EKG, then I'm like, did they have some ischemia going on? Maybe we will get a stress test. And echo assessing for wall motion abnormality and stress compared to rest. Sometimes that can vary with interpretation issues. Sometimes there is some subjectivity to reading these. Important points. If you're able to walk or willing to try, do the stress echo. Encouragement for them to do the walking, and they need to be able to lie down for 20 minutes twice because they do the echo imaging and they do the stressing, then they have to lay down again for that. Now let's learn about pretest probability. This is going to help you determine what tests that the patient should have. This is the stuff that you need to know. So exercise testing is the most valuable, and the pretest probability is intermediate. So how do we test that? Age, gender, and symptoms. So I have this, and I'm telling you, I cannot find it anywhere on the internet. So either like make your own table and copy this onto it and print it out for yourself, because this is really nice to help determine, if this person, what kind of stress test you're going to get, or if this person needs a stress test. So basically, if they are having non-anginal chest pain, so say you have a man, let's make it easy, a man that's having some chest pressure and he is age 50, history of diabetes, hypertension, high cholesterol. So I'm going to look here, and he's the intermediate, so that would tell me that he definitely needs a stress test. Now it's just determining which type of stress test that he's going to have. So can he walk on a treadmill, or can he not walk on a treadmill? Has he had cardiovascular disease in the past or not? So what's typical versus atypical angina? Remember, atypical is stable plaques, and typical is stable plaques, and atypical is unstable plaques. All right, so it has a substernal or characteristic quality of pain. It's with exertion, and then it resolves with rest or nitro. That's when you know that it's definitely more of a typical angina. They don't have unstable plaque. The plaque's there, but they have some vasoconstriction, with exercise, and then they're closing off the vessel a little bit, and then you're getting a lack of blood flow, hence having some chest discomfort. Now, atypical, you want to make sure that would be more 2 of the 3 characteristics of this chest pain, and non-angina would be only 1 or none of the characteristics. So if you're having 2 of 3 of these, say you have chest pain and at rest, and it doesn't resolve with rest, then that's atypical. If you have only 1, let's say you have some chest pain, this could be a non-anginal chest pain, but it's hard to say. I always say it's atypical until excluded or ruled otherwise. So always have that in the back of your head. I don't play around with chest pain. You shouldn't play around with chest pain. And I'm sure you guys know, we're all nurses. We know that we want to play safe than sorry. You can't live without your heart. You don't want to mess around with it. So remember, women always present differently, and I'm sure all of you know about that already. Women are more likely to have one vessel, more than likely to have one vessel blockage than men. And a lot of women have microvascular disease, and they just have different symptoms. These are just some sensitivity and specificity for the stress test. So we have your treadmill, your exercise, your pharmacologic. So remember, exercise perfusion scan is where you're on the treadmill, and they're also doing the echocardiogram. The treadmill is just a straight treadmill, no echocardiogram. The pharmacologic, they're raising your heart rate to do that. And then you have your PET scan, which rarely ever see. And then you have your stress echo too, which is actually the exercise perfusion scan is where they do the nuclear med, I'm sorry. And the stress echo is where you're going on the treadmill and they check your echo before and then after. So as you can see, just a plain treadmill, the sensitivity and specificity is lower. It doesn't detect as much. But as you go up here, you can see how a stress echocardiogram has really good sensitivity and specificity. So you're not doing anything wrong by getting just a straight stress echocardiogram. And the pharmacologic perfusion is good too, as you can see, as well as the sensitivity for that. But just know that the sensitivity specificity for a regular stress echo is good. I'm not going to read through this, but this is just appropriate use criteria, that there's always risks and benefits to procedures such as radiation. We need to use clinical judgment when we're deciding if we should order testing for these patients, and choosing wisely. We want to avoid using stress tests, using imaging with radiation if they have a low risk. So if they have no symptoms, if someone's coming in and said, I'm worried because my dad had a heart attack at 50 and I'm turning 50, there's no reason why you can't get a stress echocardiogram. You don't have to get imaging. And I provided the link if you want to read more into that. So just remember, with radiation exposure, one imaging study is about 63 chest x-rays. It just depends on the amount of radiation used. And cardiac cath has about 30 chest x-ray equivalents. So, I mean, it's definitely giving you some radiation. You have to weigh the risks and the benefits. And I always tell the patients that, well, there's radiation involved, but I think you should have this because you really have some changes on your EKG, and you're telling me that you had a stent put in 3 years ago and you have not had a repeat, and you've been more short of breath. So yes, you do need to have the perfusion stress test with the nuclear med. There are no benefits to society if we decrease the number of MIs to find out that everyone is developing cancer. So it's true. There's no safe lower limit of X-ray exposure. But again, it's one of those balance things. So, don't be so nervous where you're like, okay, oh my gosh, I'm going to expose them to radiation. But yet, maybe they should have the perfusion scan. I mean, I order Lexi scans all the time for the pre-ops because I see a lot of them with already established heart disease with symptoms, and they're going for major surgery. So I know it's kind of hard to read this, but this is what I had at the time. So if you have like high risk, intermediate, or low risk, it's just another way to help you determine if you should order one or not. So if they're low risk, you can do a routine EKG and a stress test. If it's positive, then you go to the imaging modality. If it's positive, then you do a cath. So it's basically what happens. You send them and something's abnormal, and sometimes they'll have them go ahead and do some perfusion studies, or they'll go right to the cardiac cath. Depends on the cardiologist. Anybody that has an abnormal stress test sees cardiology. So, but if they have intermediate risk, your Framingham score is greater than 10%. If they have some symptoms, their EKG is borderline. You really only get markers if they're in a acute area, like in the hospital, inpatient, or in the ER. I always say if you feel like you need to draw troponin, in primary care, they shouldn't be there. They should be in the ER. So always ask yourself that question. What are you going to do with it? What if their troponins up? They should be in the ER. So you should be sending them to the ER instead of drawing a troponin. But just think about these things. Even if they have a borderline EKG and some symptoms they had 2 weeks ago and they have a high Framingham risk, you probably want to get some imaging with the stress test. So I get like the Lexi scan, or you get a dobutamine echo. So cardiac cath is still the gold standard to actually go in and see if they have any blockages or not. It can check for microvascular disease which is more common in women. But anyways, with the cardiac catheterization, that's, obviously it's kind of like an upper endoscopy, a colonoscopy. You can go in and actually see for yourself if you have any blockages. Do these need to be stented? Do these need to be just monitored? Does this person obviously would need lifestyle changes? And echocardiography, as I said before, it evaluates overall heart function, your systolic and diastolic. And remember, it checks your ejection fraction. So that means that 60% of the total amount of blood in the left ventricle is being pushed out with each heartbeat. So if somebody has a lower ejection fraction and normal is 55 to 70, then do they have some systolic heart function abnormalities? If it's normal, they could have some diastolic dysfunction because remember, it's not the heart pumping, it's actually the at rest, diastolic, it's at rest, and what happens is your ventricle becomes stiff, so it's unable to fill all the way. Whereas the systolic heart failure is it's having a hard time pumping out, and that's where that ejection fraction comes in, where it starts going down. Also looks at your valves, it looks at a lot of things, so it really gives a good overall picture of the heart. And I already mentioned this here. And then I said valve stuff. If you have some moderate aortic regurgitation, you want that watched. If it's mild, a lot of people have mild regurgitation. If it starts getting to moderate, they need to see a cardiologist, so that can be watched. Coronary CT, I usually leave it to cardiology to order that. So it's just another way to look at to see if they have any coronary stenosis. This is not a calcium scoring, this is different. You can assess for plaque and calcium deposit with the coronary CT. Again, this is different than your calcium score screening. This is a really quick way, but usually I don't see it done too much. Now this is your coronary angiogram. So the Cleveland Clinic supports careful use of this. And it's really only indicated for a certain amount of people. They usually will just go ahead and do a cardiac cath. Instead of just putting the dye in, and that way they'll just go ahead with the cardiac cath and take a look. Now with the cardiac cath, remember they go through the artery. It used to always be the femoral artery, but now they're doing brachial artery, radial artery. They're doing all different ways, which is much better than the femoral artery because it just bleeds and bleeds. And they actually have better ways of sealing off the artery now. I worked cardiac step down for years, and we used like the old-fashioned clamps. We had to clamp down, and oh my gosh, we'd have to hold pressure for 20 minutes, and things are a lot different now. So you have the algae patches and things like that. So who should not have a CTA? That would be chest pain during heavy physical activity, positive stress test results. You're just going to go right to a cath. You're not going to do an angiogram. You're going to do straight to the cath and see what's going on. MRI, again, is one of those, where cardiology could order it. Say they see a mass, then you would get an MRI because you can get slices of the heart to find out what's going on. So I don't have too much experience. I've never ordered a cardiac MRI, but it would make sense if somebody has like a cardiac mass or some congenital issues. But not usually. I don't see it too much with chest pain. But I guess if you maybe have a chest pain syndrome and you can't find anything else, they could probably get that. But definitely I can understand even with a itis, like an endocarditis, pericarditis, myocarditis. And here's the calcium scoring that you might see, or people might come in and say, hey, I got some calcium imaging and my calcium score is high, now what do I do? So it's one of those things, when you get it, what are you going to do with the results? But I see physicians accepting it more and more now and saying, hey, you are at high risk for heart disease. Maybe we should check into this further, especially if their score was very high. My stepfather, although he's 90, he had a high calcium score, went into his cardiologist, they did a cath, and they put a stent in his right circumflex artery. So he did have something going on. Here's some risk factors that can determine whether your family members or you or some of your patients can get the calcium imaging, because I'm sure you will have questions. So do you have a family or personal history of coronary artery disease? A male over 45 years, it's supposed to be age. Female over 55, do they smoke or did you used to smoke? Do you have cholesterol, diabetes, or high blood pressure? Are you obese? And do you not exercise? Sometimes it says, because there's certain forms of different kinds of plaque, it might not detect on this particular CT scan. So remember, it's good to educate your patients. It's not an absolute in predicting your risk for life-threatening MI. They give you a score, plaque highly unlikely, or significant stenosis highly unlikely, or just a risk over, the next few years. Score greater than 100, that's not good. So it's basically what to do. Risk factor modification. I mean, with the high score, I'd probably send them to cardiology, because they're the experts at that stuff, and I'd probably send them for a stress test in addition, and then I'd refer them. So when are you going to consult cardiology? Well, if you're having chest pain, but you can get a stress test first. You don't want to send anybody for a stress test if you're having active chest pain. So I'm sure most of you guys already know this. If you're in the office, though, office setting, primary care is a little different. If they've had some chest discomfort 2 weeks ago, then yes, you can send for them for a stress test and see what's going on. Chest discomfort, anginal sounding with normal stress test, anything abnormal, I refer. Syncope, anybody that has a syncopal episode, they need a Holter monitor. So you can go ahead and do the Holter monitor. You don't have to refer to cardiology until you get the Holter monitor results back, or if they have another repeat syncopal episode, because you're going to be working them up. But always get a heart monitor. Either get like a 48 to 72 hour Holter monitor, or you can get an event monitor. Just depends. You have to talk to the patient. Event monitor is if they're having issues like every now and then and it's not picking up. That way they can press the button when they're feeling a certain way. The Holter is just going to check. You're still going to write down on a diary of what's going on when you're feeling certain ways, but it's just going to do that straight 48 hours or straight 72 hours. So sometimes you might not pick up any abnormalities. Some people that have syncopal episodes or irregular heartbeats or palpitations, they'll actually implant a loop recorder, and that can stand for a couple years or even more. That's being monitored by an electrophysiologist to detect if they've had any runs of VTAC and things like that. Any heart failure that you can't manage in the primary care office should be going to the cardiologist or a lot of places of heart failure clinics. Most of the patients when I did internal med saw the heart failure clinic. It's actually good to have different eyes on the patient. And then new atrial fib, when not sure if rate versus rhythm control the best, I sent all my atrial fibs to cardiology at first, get them on the right medications, and then if they're managed, then there's no reason for them to go back unless they're having an issue. Or if they're on an antiarrhythmic, they should be monitored. So anybody that's on like Ridmol, Sotalol, they should be monitored and watched in cardiology. Amiodarone, the amiodarone, you definitely want to watch the TSH and stuff. So, and then you want to definitely work up shortness of breath before consulting cardiology. But here's some pearls. Consider your pretest probability, evaluate the symptoms, counsel about radiation. Remember, an echo is easy and cheap, non-invasive, no radiation, but body habitus can be an issue. For advanced testing, you always want to consult, and it's always good to have other eyes on the patient and consult with